If you're trying to prevent disease, we don't want to wait till the disease shows up.
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, welcome to this week's episode of the Dutch Podcast. Now, if you are a woman who's interested in longevity and health span, this episode is going to be particularly interesting to you, or at least it certainly was to me. Our guest today comes from a conventional background, has a master's in public health. He kind of understands the system and how medicine works from the inside out. And he's moved into longevity medicine with a really thoughtful approach. So if you've been worried, and if you're a provider too, this affects us as well. We want to practice good medicine. We want to make good, safe, effective choices for our patients. And when you're entering this space, it can be really difficult to cut through all of the information to understand what's really safe and effective for patients. We're going to talk about that today. Of course, we talk a lot in depth about hormones and the use of hormones, but we talk about other things as well. I think you're going to really love this episode. My guest today is Dr. Asare Christian. He's the founder and medical director of Ether Medicine, a premier integrative medicine practice specializing in longevity medicine, hormone optimization, cellular medicine, and, of course, in his background, integrative pain management. Dr. Christian was trained at Johns Hopkins and Harvard Medical School, and he's board certified in physical medicine and rehabilitation with a fellowship in anti-aging, metabolic, and functional medicine. Dr. Christian combines precision diagnostics with advanced therapies like bioidentical hormone replacement, the use of peptides, and other regenerative medicine therapies to help patients really get to the root cause and optimize their health span, because we all want to age on our own terms, right? So let's go ahead and dive into this episode. Well, Dr. Christian, welcome to the Dutch Podcast. I'm so glad you're here.
Thank you so much for having me, and I'm excited and honored to be here.
Well, I'm personally thrilled to be covering this topic today on female longevity, kind of from that 50,000-foot view, because it's really interesting. We know, clearly women outlive men globally. There's these trends that have existed for quite a long time. And I really want to dive into, why do women have that longevity advantage, and what can they be doing to kind of maximize their unique physiology to get an even greater advantage. So I'd love to start by just having you kind of unpack biologically, what are the most compelling reasons that we understand today for why women live longer than men?
Yeah, so I know it's a great question, and there's multiple ways to kind of look at it. We can look at it from a biological standpoint, from sociology, culture, and other things. But I think specifically for people to have a third-person objective science viewpoint, a couple of things that we know that improves longevity for women is the fact that they have this XX chromosome. So men have, so from a chromosome standpoint, men have the XY, and the Y is shorter. So sometimes there's genes that are deleted that are protective. So that's one area where women have advantage, and even dealing with disease that has a specific genetic predisposition, whether you're a male or female. So that's beneficial. And then the third piece, which is something that I think, the second piece, which is something we're going to get into a lot more, is estrogen. Estrogen is very protective. It's protective for brain. It's protective for cardiovascular health. It's protective for immune health. Immune health, cardiovascular health, metabolic health, all of those are things that influence longevity. And then from a third piece standpoint is because women have this extra chromosome. Again, it goes back to that, but it's metabolic activity. Women have this activity to influence mitochondria to make energy efficiently, because you have all these estrogen receptors also in the inner mitochondria that helps you to make energy and also decrease oxidative stress. So those are all biological things that are very helpful to support women in terms of living longer.
Well, I can't wait to dive into all those topics. I'm also really curious, and I think for people who are listening, they heard a little bit about your background. Trained at Harvard, trained at Hopkins, physical, rehab type of background. What led you to be so interested in this longevity field?
Yeah, so first, I'm so grateful that I'm here because, a couple years ago, I had no idea what any of these things that we're going to talk about was about. And as you mentioned, I got trained very well. I went to Hopkins, I did
Right.
Harvard, I have an MPH, I have all of those things. So that place gave me a good understanding of how to diagnose disease, how to treat disease, how to make sense of science. But we know that to really help people to heal, then you have to understand how to solve health. And one of the things I've come to appreciate and trying to stretch for people is there's a difference between solving sickness and solving health. And I think when we're in training in medical school or in PA school, wherever we get our training, in those areas, you learn about biochemistry and pharmacology, all of this things that actually influence physiology, how our system is supposed to function well. But then once we get into residency, we forget about all of those physiologies or how things are supposed to work, and now we start focusing on how to solve sickness. We don't talk about nutrition when you're in the ICU. We don't talk about exercise when people are coming into the hospital as a way to produce health. So what led to me coming here was background into pain medicine, rehab individuals, spinal cord injury, brain injury, and there's a limit to what I could do for them. But I know the body has that potential, so it became necessary for me to dive into how do I learn how to solve health. And the interesting thing is, with all my background in training, I actually forgot how to solve health. So I have to go back to relearn all of these things. So it's really important for us to get there, because once you get there, then you can realize that whatever the intervention is, whether we're giving medications, we're giving hormones, we're giving surgery, injections, when people are healthy, their outcomes are better. So that's what led to this journey.
I love hearing that story, and it really resonates with me. Like, I was looking at an MD path and ended up training as a naturopathic doctor, which it's interesting because I think culturally we're looked at as less.
Yeah.
From an academic standpoint, certainly by a lot of like my MD peers or ND colleagues, I'll say. Maybe they wouldn't want to be called a peer, and that's okay. But it's a very interesting point of view to hear the way you're describing it, because I see the same thing, and that's what drew me to naturopathic medicine, because the way I think about the healthcare system is really like a pyramid, just like the old food pyramids. And the bottom of that is how we live.
Yes.
That's ultimately what determines our health. We're not random victims of diseases. There's genetic components and things that are outside of our control, but I really don't believe that it's some kind of random occurrence. Absolutely. Then as you move up the pyramid, you have, let's say nutrition, and then medications, and then the very top is like surgeries. And we need all of that in our healthcare system. It's interesting because when you're in training for both of our backgrounds, you start at the bottom.
Yeah.
You start at physiology, but then as you move up what I would call the therapeutic order, and you learn drugs and surgery, once you're out, it's all you do is drugs and surgery. And it's not that that's bad. It's just maybe not the best tool in the toolkit for where someone's at. And we tend to do nothing as people's needs kind of climb up that ladder until they hit the need for a very intensive intervention. And that's what drew me to this type of medicine. And longevity is such an interesting piece of it, because it's adding a layer of bringing people back down that ladder, bringing people back down that pyramid, which I think is so exciting.
And it's foundational. And I do appreciate that now, because I have friends who are ND, and we learn the same things in medical school. And then once we start practicing, we just prescribe medicines, and we lose all the other benefits, the foundational things. Because again, the medicine is not going to work well if people are still eating junk, they're stressed, their hormone imbalance, their gut is not fixed. And as a pain doc, one of the things that I came to appreciate, just the fundamental simple things, fixing somebody's gut, and how that will translate to resolving chronic pain conditions, irrespective of everything else that's been going on. So definitely this is something that, I hope that my MD colleagues will come back to the foundational things, because that's what translates for our patients. I got out of training thinking I know all the evidence and I know everything I can do for people. And then you realize, humans are complex. This is a complex systems. And learning how to find outside, other ways, other alternative that comes back to the cell. Because what I knew was, this is the medicine, this is the symptoms, this is the protocol. And being able to think outside of that and say, what is going on at the cellular level that's driving this disease states, and what else could be implicating, potential response to therapy. So grateful for the journey being here now, for sure.
Yeah, absolutely. Well, shifting back to the topic today, I think one thing that's so interesting, I heard this really funny, really skit from a female doctor who'd said, when I'd hear women talk about longevity, they're not talking about living to 120. She was like, maybe men talk about that, but women don't talk about that. women talk about wanting to be able to play with their grandkids and travel when their kids are out of the house. And really, it's a lot more about the term we're using now is health span, right?
Yes.
You want to have this rich, long life where you're free of pain, you're able to move, you're active, and you're not limited by your health. So you started to talk a little bit about some of the things that biologically differentiate women. And let's start by talking a little bit about estrogen.
Yes.
You know, estrogen is this really protective hormone. Can you walk us through some of the ways that estrogen supports our health? And I know it's many systems of the body,
Yes.
but where would you want to start?
Yeah, I think this is super important. And hopefully the audience will really take this and let's figure out, we know that estrogen is protective. And we know that at some point we start losing estrogen. So we lose that protection. That's the main point. I'll get into the benefit, but we have to figure out, understand all this benefit we get from estrogen, and then how do we maintain that for overall health, because it does goes down. So one area that's super important for longevity is brain health. So brain health, without the brain, then none of the systems works as well. So estrogen does modulate neuroplasticity. It does modulate neuroinflammation. These are inflammation within the nervous system, so estrogen plays a huge part there. And this is also something that, you know, individuals can validate for themselves. You know, women tend to be much more able to remember information, conversations. There's multiple conversations going on. They can keep track of things, right? And then the guys, we just have to give us one thing, you know. So this is something that is good for the brain. From a cardiovascular standpoint, it does the same thing. Women are protected because estrogen, as we talked about, actually modulate oxidative stress. And it's all about metabolism, energy of the system. So even when we're talking about hormones, how effective, how much energy is available, the efficiency of making energy definitely influence all disease states, in my opinion. And I think that's something that it's well established. So from a cardiovascular standpoint, mitochondria works a lot better. Estrogen also does improve nitric oxide production. So nitric oxide is involved in vasodilatation. It opens the vessels out, it prevents arterial stiffness, all of these things that are not good. So that's a good place from a cardiovascular standpoint. And then we also know that estrogen also has an important modulation on immune system. Immune system plays such a huge role now as we're talking about immunometabolism in longevity. So women tend to have a better response even to vaccines, to fighting infections, because again, they have these two chromosomes that has this immune modulatory processes. And estrogen does that by downregulating this inflammasome, NLRP3 inflammasome, which turns on another protein called NF-kappa beta that leads to inflammation. So estrogen actually blocks those things. So those are ways that, you know, from an immune standpoint, estrogen is protective. From a cardiovascular standpoint, nitric oxide and making energy efficiently. And then from the brain, you know, modulating the inflammation in the brain system and also correcting some of these neuroplastic things. So those are all things that helps with overall, you know, longevity in women. Besides that, we also know that estrogen has a place in metabolism. So bone health. Estrogen does implicate or decrease osteoclast activity. So osteoclast is the bones or the cells that are breaking down bones, and osteoblast is the cells that are making it. So we know that even when women go through menopause, menopausal osteoporosis, people losing or women losing bone is something that's very unique to women. And why is that? Because estrogen is there to protect. But again, the point is that all these protections are there till they are not there. So we have to kind of come back to how do we reestablish that loss, which we know is predictably going to happen as women age.
Yeah, I love that you're really starting to dive into some of the complexities of it. Like particularly with the immune system, that's one that's so interesting because I think like most people are aware of statistics like autoimmunity is so much higher in women than in men. And I hear you say some of the positive things like women mount a better response to vaccines. I didn't know that than men, but you know, it speaks to the fact that the immune system is even different fundamentally. And sometimes that works to our advantage. And other times, especially in an inflammatory world, you're not eating well, you're not, you know, drinking clean water, whatever is driving that high stress environment, it can create a lot of havoc for women as well. It's really kind of a double-edged sword in that way.
Absolutely. And that's something that I think people should really hone in and understand. So this protection that women have because they have a better innate and adaptive response, that also, that very strength for being able to catch things and attack things also make them more predisposed to autoimmune issues, right? So when we even look at autoimmune conditions, 80% of them are female. So fibromyalgia, lupus, arthritis, all of these things that we see, and those things actually tends to come up again as women start losing estrogen. Okay, so it has this beneficial piece of being able to control the immune system very well, but then it can also be overactive. So we have to learn how to figure that out. And I see that in chronic pain syndromes. A lot of my patient population are women. And again, I don't see them when they're young, but I see them when they're going through the perimenopausal or menopausal state, and this becomes something that is difficult to navigate. But again, this is all things that are preventable if we can correct some of those deficiencies that happens as we age.
Can we talk more about that? Because I think you have a really unique expertise in that pain management world. I mean, you have just so much experience there.
Yeah.
I think I'd love to hear more about your just experiences with patients. And I think some of them are on the chronic pain conditions. I wanted to start there. But also on the just the higher likelihood of of injury, really, for lack of a better term, that happens when that estrogen drops off. Because I think, you hear about the rotator cuff tears and like things that people are doing the things they've always done, but now they're breaking when they're hitting perimenopause and menopause. So maybe start by just sharing a little bit about your experience around that with the chronic pain conditions where you started, but then I also don't want to slip away without hearing what you have to say about injury.
Yeah, so I actually I've been in this journey to kind of figure out how to solve health, but somehow hormones were this one piece. I started with systems, the microbiome and other pieces, and the hormone was one piece that I actually knew I need to get into right away, because I have women coming to me in their 40s and 50s, and they start coming up. I'm having joint pain. I'm having all these pains, and I knew that this was estrogen deficiency because we know it's protective. We also know that estrogen is anti-inflammatory. As you lose it, then there's more pain issues and other things. So it was one that I was seeing over and over, but again, it wasn't like something I was comfortable with. And even I have to kind of work with that. It's like, what is a pain doctor doing with hormones? But then once I figure out, yes, I'm now trying to modulate a cell to make good decisions. I'm a cellular medicine doctor. What do I need to do instead of giving somebody a pill for pain, a pill for sleep issues, a pill for bone health, a pill for mood, and the underlying issue is estrogen deficiency. So after I kept seeing patients over and over, I had to go learn how to solve that. And we also know that on the other hand of things, testosterone is anti-inflammatory. Testosterone is also very good for healing and things like that. And it actually does it so well that testosterone actually immunosuppress sometimes. Okay, so women have this benefit of kind of being able to kind of control things in a healthy way. So a lot of women coming in, joint pain, all these pain conditions, and when I check their hormones, there's dysregulations. When you solve and balance the hormones, pain gets better, sleep gets better, their metabolic profile gets better. You also prevent bone disease. So that's kind of been the whole philosophy for me. Is like, how do I figure out how to solve the problem, not only translating to pain resolution, but also overall health optimization, and it all a function of going to the cell and fixing what is dysregulated. A lot of women come to me, they're trying to work out, they've been doing the same thing that you're talking about. They've been working out, I'm not building the muscle, I don't have the same recovery. I've changed my nutrition, I've changed all of these things, but at the biological level, there's a decrement in their resilience. And where is that coming from? Loss of estrogen, loss of progesterone, loss of testosterone. So all of those things that I've seen and has really shaped my journey. And in fact, I'll tell you a story that is, it was a very sad story. When I started this practice, my inception was I wanted to figure out how to make people healthy as a way to solve pain. And I had this young woman who came in. Now that I look back, there was all this hormonal dysregulation. She had pain everywhere, pelvic pain, jaw pain, other things. And eventually this young lady, without any other issues but chronic pain, took her life. And it really bothered me. And I from then, I need to figure out how to solve this, because we have all these excellent health systems around here. I'm in the Philly area. We have Penn, we have Temple. We have all these big institutions. And none of us were able to help her until I recognized that there was all these other cellular things that are going on instead of just signal blockade. Everybody was doing gabapentin and injections and all these fancy procedures, but not really understanding what is driving this whole hyperactivity of her nervous system, hyperactivity of her immune system. So definitely getting to understanding some of these things really makes a difference. And I hope that more clinicians, irrespective of whatever your field is, this is physiology. I'm a pain doc, but if I can improve your physiology, then everything else I do works a lot better.
Yeah, what an interesting point of view, and thank you for sharing that
Yeah.
story. It's terrible about your patient, but I can see how that could have such an impact on how you approach care because, you're right, like blocking a nerve signal, blocking a pain signal, when there's underlying pain, it's almost like when a fire alarm's going off in the
Yeah.
building, like putting a pillow over it to make it quieter, but like not going to try to figure out where the fire is. And I think you hear that a lot in health, but I think in pain, it's one of the most profound pieces. It's like then another fire alarm's going to
Yep.
just start going off, right? So I love that you addressed that and you said, I'm a cell health doctor. Because ultimately, like you're a firefighter, you're going to try to find the fire.
Absolutely.
It's just such a different point of view.
Yep, that is so important, and it's just getting people to understand that when the system has better resilience, everything else we do has better outcomes. Surgery has better outcomes. The energy medicine, the acupuncture, everything else. So it's not just and that's one thing I'm starting to learn, and it's just like get the system better because the system has all this intelligence to actually do the right thing. It's not how much we've given in, how much we put in. It's all about the foundational things. Let's get it better so then if you put the hormone in, it works a lot better. A hormone in a person who is not balanced from a psychological standpoint, from a nutritional standpoint, from microbiome standpoint, is not going to have the same outcome as somebody who has all of those things kind of balanced and optimized. And so optimization of physiology and respecting that intelligence is super important.
Well, let's dive in a little bit more into how you apply hormones in your practice because, you said, well, like I'm a pain doctor. What am I doing with hormones? But it seems like I'm a pain doctor. What am I doing without hormones?
Exactly.
Right? It's really the right way to approach this. So we know that like a lot of providers, we start with standard serum hormone panels to just get a snapshot of what's happening. Can you talk a little bit about how adding in hormone metabolites and that whole Dutch picture has shifted the way you build treatment protocols for your patients?
Yeah, and I think that's a great question because when people start with hormones, depending on your training, you just learn about getting serum labs, which is important.
And there's nothing wrong with serum labs.
Absolutely.
We love serum labs. I do them on all my patients. Too.
Yes,
It's cool.
and that's a baseline. That's highly recommended that everybody does that. The other piece that is very helpful because again, we're trying to get precise and we're trying to get very specific to the person in front of you, and the way to be able to come and make some of those distinctions, even same person. Same levels of estrogens that you see in the serum, you give them the same intervention, somebody does well, somebody doesn't. And the piece that we need to also understand and capture is like, how does a molecule or compound, whatever we put in a body, how does that body interact with it? And more importantly, how does the body get rid of it? So we need to understand metabolism. We need to understand absorption. We need to understand, excretion and all of these processes that actually leads to health. So one of the things that I gained from using Dutch was being able to see the metabolites of estrogen, because potentially if we take a pathway where things are not going the safe way, this can actually predispose people to DNA damage, and then that can lead to potential oncotic or cancer or whatever it is that comes up, or even increase in senescence because there's a damage to a DNA. So this test gives you that, and then also understanding metabolites. Beyond that is also looking at the stress response, because hormones don't work in vacuum. We have to, when we're talking about hormones, we have to think about not just sex hormones. We have to think about cortisol, which is a big piece of how all of these hormones regulate. Your thyroid hormones, your insulin, all of those things are talking to each other. So one of the ways to kind of get a better sense of what is also happening with people's HPA axis is really understanding cortisol curve. And I love the awakening curve, which actually shows you what it is, because I do check cortisol in the serum.
Yeah.
And then you just
I love that too, but personally, I have a love-hate relationship.
Oh, you do?
with the cortisol awakening response right now, so it's
Yes, it is, but I think
Even if
there's
that
a lot
was
more.
great.
I mean, we expect cortisol to fluctuate, but if you see a flat
right.
line, that means something has been going on for a bit. It
Right.
doesn't just show up. I mean, there's fluctuations based on what's going on in your day, but being able to kind of capture this, and if there's an impact there, it tells you, of course, all those protection you get from estrogen. A lot of stress will then implicate immune function. A lot of stress or cortisol will influence metabolic health, bone health, even make you more catabolic. So kind of having that
more
piece.
inflammatory.
Yeah. So having that piece is super important to kind of put in there. So definitely there's a lot more that you get in terms of getting precise and then obviously preventing disease by understanding what the Dutch test is giving you.
We'll be right back with more. If you're already running Dutch tests in your practice or thinking about it, there's never been a better time to become an official Dutch provider. Why? Because we go beyond lab testing. Our provider community gets exclusive access to clinical education, in-depth report interpretation, training, monthly case reviews, and one-on-one clinical support. Whether you're just getting started or looking to sharpen your functional hormone expertise, we give you the tools to grow. Join thousands of providers already making a difference. Visit DutchTest.com today. Welcome back to the Dutch Podcast.
I love that you mentioned the stress piece, and we'll get back to estrogen and estrogen metabolism.
Yep.
But I think when you look at longevity, I completely agree with you. We have to think about hormones in totality. They're like friends at a party. They're not like you at home alone on the couch watching Netflix, right? So it's all about who's at the party, and that changes the vibe, and it changes what's happening hormonally overall in the system. So you have to be looking at everything, and cortisol and adrenaline, noradrenaline, like all of these hormones have such a big impact on how all other hormones function or don't function. So I'm really glad that you bring that up, and especially for women, I think, who tend to be carrying a lot or juggling a lot. Yep. Men have a lot of stress too. So it's not, this is really not even a gender comparison, but for the life we live in America, stress is a component of disease for probably almost everyone.
Yep. And I think even for women, the psychological stress on women is well documented than men have to experience. Women tend to be the caregivers. They tend to have this protection that they have from estrogen. Now they have all this psychological stress that creates cortisol, and then kind of takes away that benefit from women. Women also tend to have a lot of sleep issues as hormonal things change. Sleep, so important in modulating every function in the body, specifically metabolic health, immune health. So all of those things, the environment we are in tend to then take away, and then with time, right? As we age too, we kind of lose that resilience. So the idea is becoming aware of those things, and how do we put into place infrastructure that support women as they go through their journey from perimenopause, menopause, and postmenopause. And it's simple science that we are talking about. We can really make a difference.
Definitely. Now, you did mention about the way that hormone metabolites can also interact with DNA and cause DNA damage. So I want to talk about that a little bit too, because that's really pertinent to the topic of longevity.
Yes.
There's data suggesting that certain metabolites of estrogen, these 4-OH metabolites, if you don't have enough antioxidants around and enough glutathione around, they can become DNA damaging molecules, these DNA binding adducts, and they can cause some trouble. And if you do have the right nutrition and antioxidants and things around, they get metabolized harmlessly. So that's really what you were referring to there, I imagine, when you were talking about
the pathways.
Needing to know, especially if you're going to be putting hormones into the system. A woman's going to take estrogen. Yep. I can tell you're wanting to make sure that path is clear.
Absolutely. So that is one of the biggest value that I feel like I get from the Dutch test, is really understanding the metabolites of estrogen. Because yes, when we get to a place where we're going to be putting estrogen into the system to support and to replenish what's being lost, we need to understand what it's doing in the body. Okay. So understanding phase 1 metabolization, phase 2 detoxification pathways, super important. So making sure that we're shifting things more towards the 2-hydroxy and the 16-hydroxy instead of the 4-hydroxy. So this gives you that picture. And then it also goes beyond that to really understand the metabolites also of androgens. That's also important for us to understand. And then again, going back to even DHEA sulfate, which is one of the things that a lot of people don't pay attention to in the longevity space. And it's one of those that has this direct relationship. And we know that as people age, it's very predictable. As people age, it's going to continue to go down. And as that goes down, it affects immune function, it affects resilience of the system. So those are all important markers to kind of start. And again, is thinking globally. It's not just that. we got to fix the gut. Because even when we get everything, once you have that information, what else do you do with it? So what I would recommend, and I think I'm jumping ahead here, is anybody which, people are in different stages of their understanding and their education. And when I got into this space, I have to kind of learn a little bit, and I'm still learning. There's so much I don't know.
Learn. I'm still learning.
We are
and
all
I've been
still
doing
learning.
this for 20 years.
So getting people to kind of have, take one thing in there that makes sense to you, and what else can you do with it, okay? If you know how to fix the gut, then the third phase of that is how do we get things to pass through? So these are all important things that you kind of have to work on. And then the longer you stay in here and do more, you validate from your patients, and you keep doing the right thing for the right person in front of you the next time.
Yeah, definitely. I love that you mentioned the androgens, because the androgens are really important for women as well. And
Absolutely.
And I think we all love talking about estrogen metabolites, but I've been like a little bit obsessed with androgen metabolites lately. This year, we wrote a white paper on it last year, and it really became on one particular metabolite called 5-alpha androstenediol, which I find to be so interesting for women, especially.
Is that the inflammatory pathway? Is that the one that tends to be more inflammatory? Oh, no.
No, it's not inflammatory, but it's a very potent androgen. So essentially, like for you listeners who might be new to this topic, when you make testosterone, it gets metabolized. And I think most providers know that one of the metabolites is DHT, dihydrotestosterone, which is about 3 times as potent as testosterone itself when it comes to binding to the androgen receptor inside the cell and like triggering an outcome. So DHT is the one that's associated with like male pattern baldness and prostate issues, because it's so powerful in men. And in women, it's also, and this is what the white paper was on, it is the most statistically significant androgen, including testosterone in that pool. 5-alpha andro is more statistically significant when it comes to its association with symptoms of high androgens like hirsutism and acne and androgenic alopecia. It is more correlated with those symptoms than testosterone itself by a lot. In fact, like in women with PCOS, I've talked about this so much. So, and I'm sure you already know this stuff, Dr. Christian. So, but I'm really sharing for the listeners. I think it's so important to know that when women with PCOS are tested, their serum hormones and urine metabolites, and then women who are healthy controls, serum hormones and metabolites, the only one that is completely differentiated between those groups, there's no overlap in the range observed, is 5-alpha androstenediol. It's a urine metabolite. So it is one we test for on the Dutch test. In fact, last year, mid-year, we pulled it to the first page for women's reports because it used to not be. But it's so important. And when it comes to hormone therapy, I think it's a really clinically relevant marker as well, because if you're going to put a woman on testosterone, usually you use about 1/10 the dose for men, and most women do fine on it, but some women don't. It's too much. And some women need more. And I think that marker, we haven't published on this, but women, I think that marker could really tell us what women would be at more risk of side effects, because you can see who is making a lot of that, either due to metabolic preferences or due to how much testosterone they manufacture in a cycling female. So anyway, super interesting. I'm really glad you brought that up, because it's an area of the report for women we don't talk that much about, but I think we should be shining more light on that. So thanks for giving the opportunity for that.
Absolutely.
I want to talk to you, and you started to get to this a little bit, for providers who are new. When you first started using the Dutch test, what was the first thing that your eyes like zoomed in on and said, I really want to understand this first?
Yeah, so the first thing was really the cortisol curve. I talked about the cortisol awakening curve to really kind of understand what's going on with the adrenal axis. HPA axis was something that I was familiar with, and how that plays a part in even pain processing, right? The more cortisol and all of that will influence pain. So that interest kind of drove me there. And then really understanding safety. Because I think if you're new in hormones, depending on your background and where you've been, you will have this idea or this notion that hormones causes cancer, and no physician, no clinician want to give anybody cancer, right? So it's something that it's so programmed in us that anything we first do no harm. So people get very worried about this, and it's all about educating yourself and understanding what kind of hormones and understanding people's picture. And the piece that I like about the Dutch test is the metabolites of estrogen. Because we know that if estrogen is not metabolized well, they have this potential to affect DNA, and that will predispose individuals to disease or sickness or inflammation or senescence, all of these things that happens in the body as we age. So having a sense of doing something for a patient and then doing everything else you can to mitigate potential risk is something that I think is very comforting for clinicians. So for somebody like me who was coming in here, didn't know a whole lot, this made a lot of sense that, okay, I know that at least people are getting rid of estrogen the right way. If there's any potential for any of these things, mitigating those risks. So those were two great places for me to start. And since then, you keep learning and you keep adding more.
I have a funny story for you around cortisol and pain that you might find interesting. Our doctor team reviews any labs that are like out of the complete
range,
normal, just to like make sure that they get a clinician's eyes on it. And a lot of times we'll find contamination or in a sample or something like that, or maybe they're on a medication that's interfering, blah, blah, blah. So, but in this case, there was a report of cortisol that looked normal in the morning, and then the afternoon it was so high that it looked very much like a contamination. And that's a common contamination because hydrocortisone cream is cortisol.
Yep.
So if someone like puts anti-itch cream on their kid's bug bite, it can spike the results. But we also measure cortisone.
Yeah.
It does not raise cortisone. So we can like flip to page 3 and see, okay, it's just cortisol. Cortisone's fine. So it's a contamination. But in this case, both of them went sky high in the afternoon. And so we called the clinician and said, this is a real result. Can you talk to your patient and figure out what had happened? And they actually broke their arm. They like took their morning samples and then fell off their bike and broke their arm, 2:00 in the afternoon. And then they took their evening samples still. I don't know how they found the time to do that, but they did. And we were like, I think you should do a more normal day. But it just shows you the impact.
Absolutely.
Migraine headaches, injury things, or even just a stressful afternoon can cause that to go up, and we'll measure that on the test. I thought you'd find that funny because it's dealing with pain so much. You see these like weird outliers sometimes.
Absolutely. Pain will do so many things to change the physiology. So the body keeps score of it. Sometimes people don't even know that it's happening, but it's something they heard, something they smelled, or somebody at their work. I deal with individuals who have migraines, and sometimes it's something at the work that's triggering that physiology. So it's important to kind of pay attention to all of that data points. Yes.
So when we're talking about women who are coming into you to expand their health span and they really want to do hormone testing, are there certain times in a woman's life that you think it's most helpful or most relevant to do these more complete hormone panels?
Yes, I think I've evolved to a certain level now, but initially when I first started, I was just more comfortable just dealing with postmenopausal because I was like, great, it's happened. I know what to do there. But I think we do miss a lot because the late reproductive ages, between 35 and 45, is where we know this volatility with estrogen and all these hormones are happening. And we know we've talked about the benefit of how this is great for hormones. It's good, great for the brain, for the heart, for the metabolism, musculoskeletal systems. So that's a good place to have a baseline. 35 to 45 is great, and then during that whole perimenopause place is also super important, and then post. So I think we need to start a little bit sooner because one of the things, I'm in the longevity space, I've become board certified in longevity medicine, and I think one of the most cost-effective ways to extend lifespan, but we care about health span, how the quality of life, it's hormones. So this is such a cheap drug, and we don't use it enough. And there's so many people who can benefit from this, and it becomes something that we don't do, and then start treating the symptoms. And I gave you that example of people coming into my clinic, and that's how I even got into hormones, where they have pain, they have mood changes, they're gaining weight, they're not sleeping, and they're on 4 different medications. They're on a sleep medicine
that are high side effect, high cost,
side effect,
high risk.
and all they need is a very low dose of progesterone to help with sleep. And sleep is so fundamental to everything that we talked about here. So I think starting early, and we're becoming aware of it. So I would highly recommend between 35 and 45, get it done, and then continue to monitor individuals and try to kind of intervene so that we can kind of restore and maintain this resilience that we know women have in the early stages of life. Because what happens is that once women get into that phase where things are changing from a hormonal standpoint, then they start losing all this benefit. And women tend to live longer, as we've talked about, but then they tend to live longer with arthritis, fibromyalgia, chronic pain conditions, and that's not what longevity is about. And those are all things that, again, is preventable if we can get ahead of time and modulate these hormones as they age.
I love that you mentioned that because I think your experience is so similar to most providers in this space where you look at women postmenopausally. And it makes sense because the perimenopausal transition, month to month, you expect hormones to look a little bit different. And so you can't necessarily trust that what you see one month is the same that you're seeing every month. However, if we look at aging, the time of most degenerative aging in women is actually pre-menopause.
Absolutely.
It's actually in that perimenopausal transition that we see the cellular changes, the bone change, bone breakdown.
Yep.
The most is like the perimenopausal years, not the menopausal years. So I think it's really thoughtful to be thinking about how can we access that data and be making those changes. And I love that you're doing this baseline in women 35 to 45. That seems essential to be able to have a starting place.
Absolutely.
And to be able to keep track of where they are.
Yeah, and it's also really getting women to understand that, because I talk to a lot of women about this, and they go, well, I don't have any symptoms. I don't have any, and I think the narrative is, if you have symptoms, you're having nice sweat and you're having this is when you need to start thinking about this. And what I talk to them about is really getting them to understand there's two lenses of how we look at this. And, it goes back to, how do you solve sickness and how do you solve health? So if you're trying to prevent disease, we don't want to wait till the disease shows up, okay? And then it's also not just symptoms that we are solving. There's other things that becoming dysregulated, even with time. So getting people to understand that, this is actually, we are trying to help to prevent bone disease. We're trying to prevent muscle loss. We're trying to prevent diabetes. I see, now that I do hormones, I see all the dysregulations that are happening. And if people have not been here sooner, then they've been exposed to statins and all of these therapies. Not that there's not a place for them, but the underlying issue is deficiency in a hormone that corrects that and built on it. And I've seen, and I've now actually become, and this is not a whole lot, I've seen 3 women in my clinic who came in and they've developed fractures. These are healthy people in their 50s, right? And they've been fine. They didn't have any nice sweats. They are perimenopause or sometimes postmenopause. And then one day they have a bone disease. And this didn't happen overnight. This has been happening for the last 10 years, the last 15 years. So we want to get ahead of it. FDA approval indication for estrogen is bone loss prevention. And I see so many women who they're told, wait till you're not having any symptoms. And sometimes I think it's just because the providers don't have the knowledge in terms of how do I prevent disease? I'm not just preventing bone loss. I'm trying to prevent brain loss. I'm trying to prevent cardiovascular disease. And then also improving quality of life and resilience, because women go through this where they're just like, it's just part of life, because, the doctors are saying, this is just what happened when you age. And we know for sure that that's not the case. And we want people to be as healthy as possible.
Yeah. I went to a talk last Friday with Mary Claire Haver. She just released a new book. She's I'm sure you've probably seen her on social media. She's an OB-GYN. But one of the things she highlighted was that clinical changes are very slow to be rolled out in the medical world. It's faster now thanks to social media. Like the application of vaginal estrogen that got, approved, like so many women are asking for it now because social media, like, Kelly Casperton, Rachel Rubin, all these people are talking about it. And so patients are hearing directly and it's growing. But if you think back to before social media, it's hard to imagine that time now, we were waiting on doctors attending their annual meeting or receiving communications around changes to standard practices. And even the development of those practices or like the standards of care that, that get published, those are years and years after the research is published. And so I think that's one thing that longevity medicine is very keen to, is trying to draw those conclusions as early as possible that can benefit patients. I'm talking about women in hormones in this case. But like you saw more doctors in this field using hormone therapy after WHI said not to, as the research started to come out before guidelines were published, new guidelines were released by, ACOG or Menopause Society. And I think that's it takes a lot of work to follow the research, but it's really forward thinking. And I love that you're doing that in these areas. It's something to be thinking about. And I would just say to patients who are listening, a lot of times there's research even before the practice changes.
Absolutely.
So make sure you're working with a doctor, like Dr. Christian, who's paying attention to those things and who could have a conversation with that, about that if you brought that stuff in.
And I think one along the same line, things that individuals have to recognize is that how we, I have a public health background. So I understand, policy and how health is determined and all of these things. And how we deliver health is influenced by how healthcare is financed. It's not based on
That's,
science.
I'm,
It's not based on anything else. Okay.
yeah.
So
Tell us more about that because you have a unique perspective with your MPH. It's like, yeah, it has to work for the whole system, not necessarily the individual.
exactly. So it's all the things that we do in medicine. Yes, you talk about the fact that sometimes even a beta blocker, we knew beta blocker was very life-saving for so long. It took 20 years before it became practice. There's so many things that we know can move the dial for individuals for overall health, but because insurance doesn't pay for it, first of all, doctors who are in that space don't have any incentives to go learn about how do I do something else. So people need to understand, and I think people are becoming more aware that we have to do a lot more. There's a place for conventional medicine. It's great for diagnosing disease. It's great for managing disease. Well, we'll say great, right? Because we'll save your life and we'll see what else we can do. But really, health, that is not something that insurance pays for, or that's not something that most physicians, based on their environment, are incentivized to do. So it's really important for people to listen, and then you can also validate for yourself, because sometimes people even feel like crazy. They tell me my labs normal are fine, and yet I don't feel good. I can't sleep. I can't do all of this, and it creates this stress for people. So it's really getting people to understand that there is so much that we don't do because insurance doesn't pay for it. Okay, and then because insurance doesn't pay for it, it doesn't mean that it's, and then people have that association. Oh, because the conventional doctors are not doing it, that's not safe, and they tend to actually kind of question the science from people who are actually applying the things and making it N of one. And I think what we have to understand, even from a clinician standpoint, is having agency. We go to medical school, we go to naturopathic school, we go to PA school, whatever it is. We learn things, and then we have guidelines. Guidelines are there to guide you. It is getting to the place of having wisdom and trying to understand who is the person in front of you. Is this guideline going to benefit them? Or is it going to harm them? Okay, and I think sometimes that's what I see happening, where patients will be like, they tell me, look, I can't do this, or this therapy, or they will put somebody on estrogen. I go, they have to stop it because I was having side effect. Well, the dose was too high. Or they would say, well, I started having bleeding, and they were on low doses of progesterone. So really, there's all these nuances and precision that need to be put in place for the person in front. But anyway, I guess that's a long way for me to say people don't need to understand that the system is not designed to solve health. It's designed to solve sickness.
What you're saying really is striking to me. And here's where I think I love your point of view, is that you said, like, you need to work with a doctor who is applying the science, even if it's an N of one. And so there is this cultural, and this is like I think sometimes for good reason, longevity medicine culturally is being challenged by conventional medicine. They're being criticized, right, for maybe being, I don't know, cowboys and like a little bit too much of a Yahoo, for lack of a better phraseology there. But there's a spectrum here with providers who are reading one rat study and applying it to humans broadly, using things that are manufactured who knows where. And then you have, on the other side, the conventional model that waits until there's firm practice guidelines published around some kind of new modality and FDA-approved drugs available and whatever. The most conventional, slowest adopter, let's say. So you have the early adopters and the late adopters with new things. And I think with longevity medicine, we tend to be more on the early adopter side, applying science. But there is a point where it's maybe too early. How do you weigh that from your point of view? Like, how do you make a good decision in your practice when you say, this is enough for me to start to do it?
Yes.
Whereas last month, I would not have applied this in my practice. And what should our longevity docs with this point of view, like, what should they use to determine that? Because I think it's really hard to make those good, sound decisions for your patients.
Absolutely. And that's an important question. And you even kind of alluded to this. So first of all, there's so much science, and a lot of the science starts in animal studies, okay? So a good place to start is there a human study for this particular intervention? There's so many things that are out there, and the things that really move the dial are very simple things, foundationally. I mean, those things are not changing. There's all the cellular pathways in our physiology that has been there. They're not changing. It becomes, how do we signal that pathway with maybe new technologies or new compounds or whatever it is. So one, it has to be something that has, human studies. Two, something that is safe. It has to be safe. It has to have a safety profile that you feel comfortable with. And then three, having had some experience with it, meaning either you as a prescriber has done it, or through your mentorship or other people who have done that, because you may have a patient in front of you where everything else you know has not applied. And maybe this is one thing that may change the dial for them. They are already ready for it. They don't have any other options. This is the person you try this in to kind of help. And then we have to have a way to track it. Okay. So I always ask patients, how long have you been on this supplement? How long have you been taking this? And then I ask them, has that changed anything for you? And they go, no. So why are you still taking it? Because somebody said I should take it. Okay. So that's kind of like my way to kind of look at stuff. And you don't have to be somebody who understands how to appraise literature. You don't have to do that. I have an MPH, so I can make sense of data. I can make sense of science. But the foundational things, is it safe? Do we have human studies? And even if those things are not there, you still can, potentially explore it. If the person you have in front of you don't have any other options, and those are how we get these breakthroughs, provided it's safe.
Great. Now, when it comes to women and longevity and improving health span, I know you're exposed to all the latest and greatest. What are the things that really get you excited that are kind of entering our space right now?
Yeah, so I think one of the areas that we're still struggling with medicine is precision, right? Our physiology is so complex, even though we have same genetic information, the epigenetics and the environment. So really getting clear on, now we're getting very good with proteomics and understanding aging of the cell and what goes on organ-specific aging, which I think is very interesting. And even understanding ovarian aging, that's also an area that's super, super important to understand, because as a group of individuals on the planet, we're not having as much babies. And that has some implications in other ways. So we have to think about that. There are senolytics, there are cinemorphics, there's all these new therapies that are coming. But what I'm excited about is the pace of the knowledge, and then having AI to also help with the delivery system, guiding people to make the care that we deliver very easy. Because sometimes it's not lack of information, it's how do we translate that for you, okay? People may have a plan, they don't know how to execute. So if there is the infrastructure to help them to execute, having ways that people can see and validate for themselves. So wearables, those are all exciting things that I think is going to be great. But hopefully we'll get to a place where, from a hormonal standpoint, things will get precise. What version is good for you? Is it going to be a topical? Is it going to be, injectable? How is your body, absorbing? How is your body metabolizing? How is your body elimination? At least we have some of those, data point from what we get from Dutch. But getting those precisions will make a huge impact in how we deliver care.
Well, I think that's an awesome vision to work towards.
Yes.
And thank you so much for joining me today. It's been really great to talk to you and get your perspective. And certainly we're glad you're in the Dutch world. Thank you for sharing your expertise.
Yeah, thank you so much for having me. Thank you for the work you do in educating all of us here and helping our patients, because it does make a difference. It makes a huge difference. So thank you for the work you guys do.
Fabulous. And thank you to all of you who listened today. If you want to learn more from Dr. Christian, where is the best place for them to connect with you?
Yeah, so my practice is called Ether Medicine in Wayne, a suburb of Philadelphia. And people can reach out to us either by phone, 484-806-1101, or they can also go to our website, ethermedicine.com, and Ether is AETHER medicine.com.
Fabulous. So we'll make sure we put all the links and contact information in the show notes too, if you guys didn't catch that or you're driving. And thank you guys again for joining me today. If you like what you heard today, remember we release a new podcast every Tuesday. So be sure to subscribe to the Dutch Podcast and follow us on social media at Dutch Podcast. And we will see you next week.
Thank you so much.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.